that there are two important reasons that we are going to end this debate on the dot, as they say. Two reasons. You need a lunch, and I need to fly into a taxi and go to the airport. So I'm very delighted to start off this debate on the summarizing, or actually trying to, with the rich material that we have seen and heard over the last 2 days, I think it would be nice to have this grand debate. And a grand debate also requires a grand panel. And yes, we have that. And I'm very honored to have you here. And that means that sort of the objective here with the debate is trying to, in my notes, to try to pressure test some of the actionable, pragmatic, feasible and evidence-based deliverables of what we can do in order to enhance data quality. Since we have limited time, I will be terse in my introduction to the great panel, but I will be terse in my presentation of you. I think this is great, and this is also a great work by Dipak in order to provide such excellent mixture of important stakeholder perspectives. We have Pascal Verdonck, which is representing healthcare, and that is very important. And he is Vice President of Belgian Association of Hospitals Managers. Then we have a representative for the whole pharmaceutical industry and also life science industry, Nigel Hughes. He is a project coordinator, scientific director of the European Health Data Evidence Network, EHDEN. So we covered that important perspective. Paolo Alcini, representing a very important perspective, and that is a regulatory perspective. And Paolo, he is head of healthcare data, European Medicines Agency, EMA. And then we have Alexandre Guedes da Silva, who is president of Portuguese Society of Multiple Sclerosis. And you will take the whole clinical and medical science perspective in this debate. And then, last but not least, we have Philip Taillieu, who is founder and CEO of Cascador Health. And I put the label on you as a sort of the whole technology sector that could intervene into health data quality. So that completes the presentation of the debate. I have 4 open questions to the panelists. But before I do that, I would like to just check with you whether some of the action points, and you have to be terse, but I would like to check with you whether some of the action points that Dipak presented prior to this debate that you thought, intuitively, instantly, would be interesting to be part of an actionable list. So I will start with Nigel.
Hopefully, is that working?
Yeah.
Yeah. Okay. Great. Thank you very much for the invitation to be part of this grand panel and with my illustrious colleagues. And thank you also for asking me to start, in particular because our previous session ran over, so I only actually saw the last few minutes of Dipak's presentation. But so it's difficult for me to comment into entirety. But certainly that last point about making some form of statement or document from this meeting, I would warmly support. I think in essence also because often we have these meetings and conferences and there's no legacy. It's all been good and we've all learned stuff and we talk to each other and there's nice slides and so forth and maybe some propagation of the ideas. But actually that coalescing around a statement or document I think makes a lot of sense, particularly with so many diverse stakeholders involved here. And I think certainly if it gives weight to the requirement to ensure investment by all stakeholders and data quality, then even more so as well. And I think from whether it's from an industry point of view or indeed other providers' point of view, I think it's probably, excuse the expression, it's an absolute. I don't think anyone could argue with the need for it.
right? Paolo?
I think that one of the probably most important point that came up is to invest on patient, to make sure that the patient are able to decide on the data that they own, his own data, and to be able to decide if the data can be shared, can be used for other purposes. And that is going to be the first step. So actually, from the starting point of all this, so to collect that information in a more proper way, and probably at high quality, and that data then can be transmitted and used in primary use, secondary use, etc. And all the other activity that you need to do from a data quality perspective can be reduced, can be more enhanced.
Thank you. Alexandre?
For my point of view, or for the point of view of a patient advocate, what is important here is to stress that we need to work together. As a patient, I want to participate in the solutions that would improve my quality of life. So please try to do nothing for us without us. That's the key message that I think that is important here. Because if you try to do things that doesn't fit our needs, they become obsolete at the moment they are delivered. And I think the communion of every actors in the development of the solutions is key. So I would say that a Porto declaration in that direction would be very important for us, the patients.
Philip?
Well, I don't know to what extent I might be a representative of the technology sector, but I do think I am presenting a specific part of this ecosystem, and I am an entrepreneur by nature. And when I was listening to the recommendations, I was in fact listening to somebody who was acting like an architect. And of course, if you want to build a house, you need a plan, you need guidelines, you need incentives. But with an architect alone, you don't have a house. It needs to be built. You need workers putting brick by brick, in fact, to build a house. And I think the challenge here is not so much of creating a good plan and guidelines. And I think most of us are agreeing on the key principles, the position of the patient, the importance of quality. But now we start to get building. And there, my objective is to see as an entrepreneur, as a technology sector, to start executing use cases where data is being transferred, and to make sure that we apply those guidelines in such a way that use case by use case, data exchange by data exchange, we're starting to build that house that will give the comfort to the patients and comfort to all the stakeholders. So that's perhaps my stake on it.
Thank you. Alexandre?
Pascal.
Sorry, Pascal.
No. So I play the role of representing the healthcare actors who work 24/7 for the patient. So I'm always happy to go to a meeting where the summary has been written before I have to talk. So that's what I like. And what I learned from Dipak is, and I believe in that, and also from my colleague from Portugal, it's the patient first, no discussion. That must be in the center. And if I may summarize the slides some of you have seen before, is that you cannot create value if you don't connect first, if you do not integrate, and only then really you can create value. So it's the same with the future of healthcare. It's a value-based healthcare we can talk about later on. But first you have to connect, then you can integrate the care, and then you create value. So no data quality, no value.
Thank you. Revisiting my first open question, which is why do we need to invest in data quality? And that, of course, is the reason for this debate and also the reason for this whole conference. But I would like to just check with you, what are the absolutely most important keywords? If I state it differently, if we don't care about data quality, what would happen? So started with you again, Pascal.
Well, in daytime, I'm a professor in medical technology, but on top, I'm a governor and board member of different hospitals. And what I see when they started to pay attention in using data, not only for first use and treating the patient, diagnosis and so on, but for the reuse, suddenly people, and especially medical doctors and the whole staff, become available of the value of data quality. So by investing in data quality, you invest in the quality of healthcare. And once that awareness is there from the healthcare provider, that's a fantastic evolution for a higher level of healthcare.
Thank you. Philip?
Well, it's also about cost, I guess. Healthcare is getting increasingly expensive, and somebody will have to pay for it at the end of the day. And I do believe that high quality data will lead to more insight in what treatments are effective and how these treatments can be done at a reasonable cost. So, of course, I believe that patient outcomes are first. But secondly, I think decreasing the cost of treatment and learning from each other based on this data is critical to make it possible in the future to have a quality healthcare system.
Thank you. Alexandre?
Okay, that's an easy one. Why you need quality data? Because if we don't have quality data, all the outcomes that can be achieved from that data doesn't mean nothing for our quality of life. So it's basic. We don't need chunks of data that are useless, because garbage in, garbage out, and the ultimate who pay the prices are the patients, because the diagnoses are not correct, the monitoring is not effective, and the cure will not appear. And for us, data quality means, or is central for our quality of life. That is the main aim that we all want to achieve. Thank you.
Paolo?
Yes, I think as well that is very basic question. So if, for example, if we concentrate on the domain in which I'm working, so medicine regulation, in that domain, scientific assessment and decision, regulatory decision are more and more data-driven. Therefore, we cannot perform those, the assessment and the decision, without knowing, for example, the level of data quality of the data source that you use upon. Therefore, it is really important to invest in processes, in all the elements that are characterizing the life cycle of the data, from the starting point, the collection, until the analysis part. Each of these process steps have their own specific data quality requirement, data quality aspect that need to be taken in consideration. And we need to do that also to gain the trust, to win the trust of our stakeholder who actually is using the medicine. Patient, again.
Nigel?
So just a few points, I think. So first and foremost, I think we all agree we should be investing in data quality, and hopefully everybody on the audience is, if not already thinking that when they got here, persuaded by what we've discussed over the last couple of days. As an industry, so in terms of pharmaceutical industry and life sciences and so forth, we spend an exorbitant amount of time, resources, effort, and money on data quality, in particular anything related to randomized clinical trials and other studies and so forth. We have to do that. You know, we have to ensure that the accuracy and the quality of the data sets that are being utilized in terms of making the discussion with, for instance, regulators and others and so forth to be as fully informed but as reliable as possible, because ultimately these products, therapeutic interventions, will end up on the market and being used clinically. And so we need to ensure that. A couple of things, I think, from the COVID-19 pandemic, I think it's just recently been estimated that only about 10% of the studies, RCTs and similar, worldwide that were conducted had actually any real impact on decision-making. And actually, quite a lot of the evidence that we saw being utilised for decision-making, whether it's a policy or clinical level, was from real-world data generating real-world evidence. And therefore, if that's the case, we'd be pretty damn sure about the quality of such data in terms of the singular individual clinical decisions right through to population and policy levels that are being made that are quite critical. And Emmanuel Alexandrakis from the WIFO Institute in the previous session published some very nice data looking at the economic impact of healthcare systems and also for COVID-19. He showed a very nice graph of the drop of GDP by most countries during the pandemic, the commensurate rise in investment in healthcare, because that's all we were doing pretty much to make sure people survived COVID-19. But then in a lag, a rise in GDP and a recovery of economies. And you could definitely say by investing in healthcare, we invested in our future economically post COVID-19. And data quality is only one aspect of that huge investment that we need to incorporate within our healthcare systems. But at the end of the day, it's data quality and whether earlier comments around data ownership and so forth, these are all intermediary steps, because it's actually about what evidence and information is generated for us to make decisions. We don't really make the decision based on the raw data. I mean, some people can do that, but generally it's about the evidence generated from it. And so it's integral, again, that we invest and understand that we are confident in this. And much of the time, and my last point is, in our healthcare systems, for use of data for research, it's such a very anonymous situation. And for many of us, we don't know necessarily how data is being used, but we have to have trust in a trustworthy ecosystem and processes and individuals involved, and a reliance on effective systems to govern this. Particularly as we're really talking about very large-scale data sets. We're not really. Sorry to say, an individual's data, generally outside maybe a very rare disease, is of not much use. We need to look at very large data sets. And that will generate an awful lot of the insights and evidence we require. So we do need to ensure we have trustworthiness and reliance on system. And I would say, personally, it's a personal view. I'm not representing Janssen, EHDEN. I'm actually speaking also as a patient. I think the pendulum is going too far. I think the control suggested by patients means that, oh, am I going to get all these emails and inquiries all the time about what's going to happen with this data? Do I want to use this research and so forth? What I'm actually interested in is I don't want to host the data personally, thank you very much. I don't want to control it, but I want to have equitable access to that information so I can have a shared discussion with my healthcare providers about my shared care planning. And so I think this emphasis on control by the individual is actually probably going a step too far in terms of the pendulum. But anyway, those are my last comments.
So thank you. And I think it's important to return to why we're here, actually. And that's why I put that question, because it's important to revisit it. And I also share the notion that wonderful things could happen to the humankind if we could really use the full scale of health data. So that covers that. So with that, I go into the second questions, and that is who is going to invest. So the question I would like to put to you first, Pascal, is what investment are most needed to improve data quality, and who needs to fund them?
Yeah, that's an expensive question, of course, especially the answer. No, in my view, and I'm of course influenced by the Belgian health system and maybe different from country to country, but there is an underestimation of the zero line of data. We always speak in the health systems about the first line, the general practitioner and the home care, and then the second line, general hospitals, the third line, university hospitals, and so on. But we are really moving very fast, what the colleagues were saying, to the zero line. That the data is around the patient. And that needs an investment from the government that the civilian who is not yet a patient, or then the patient once someone is patient, that she is aware of it, and she is able in managing that data and giving informed consent and so on. So that's a huge investment for the government. On the other hand, in the chain, and I will limit myself, of course, to the healthcare providers, they have to invest in the right people, in the staff around the healthcare people that are able to receive that data, to use it in the right way and to give it back in information. So it's another discipline, other people, other skilled people, data scientists and so on, which are not standard in the healthcare. So for the healthcare institutions, they must be aware that connected care and integrating the care with the patient at home and so on in the future needs a cockpit, and that cockpit must be supported by a multidisciplinary team. So those two are really parallel needed investments.
Thank you. Philip?
Well, I think at the end of the day, the whole society will benefit from high quality data. So in a way, it's going to be a whole society who's going to pay for it. That's at the end of the day what's going to happen. Now, the way is, how do you structure this? I don't believe in a situation where one holistic body, be it the European Union or somebody, would pay up one holistic system to create not only a system to aggregate all the data, but then also to improve the quality of the data. That's not going to work. What I do believe is that you should aim at financing different initiatives at different levels in the value chain, in the data value chain. And when it comes to hospitals, I believe as much as a hospital needs to invest in a brick building to execute its services, it needs to invest in an IT infrastructure in order to improve the capturing of data, the quality and the validation of data. And of course, as hospitals are often financed by the government, directly or indirectly, I think the government need to prove extra funding for that. This does not mean that the hospitals have to carry the whole costs. From the moment you start sharing your data with third parties, I think there are other models at play in which the hospitals need to find a way to get a refund from the investments made coming from the industry. And there again, I don't think that the industry can do all things on their own. Perhaps also their public funding would be needed to kick off processes, because in the beginning it's hard to get the ball rolling. But at the end, there needs to be a sustainable long-term business model for the industry to extract data and share data to third parties. If such a real-time, profitable and sustainable business model is not found, we will go running from government subsidy to government subsidy, and at the end of the day, you will not create a virtual circle of added value in this sector. So in the end, government or the society will pay, but it will go either through hospitals, either through intermediary players who are service providers, either through funding for research and at the industry level. That's my point of view.
I was convinced that Philippe was going to cover the gap between the hospitals and the government.
So yes, before you continue, Alexandre, I would like to just catch up what you two. I sense that there is a missing skill in healthcare, and it is kind of the political economy of the resources also, the two things, and that new skills is needed, right? Philip, you were talking about new business model and a kind of roadmap of how to do things. My opening statement about sort of actionable, pragmatic, feasible evidence build deliverables that sort of will attract and also give that return on investment to all stakeholders. And it seems to that kind of business modeling doesn't exist. Is what I
Well, perhaps not in this industry, but there are other industries we can learn from. I do not agree with the statement that the lack of quality today is hindering or hampering the business models. I think there is already quite some data in the field, structured data, which is of reasonable quality. And so my suggestion would be to validate the business model on this data. And instead of perhaps investing in very expensive technologies for increasing the quality, we should first invest in some kind of infrastructure platforms to make this data, which is already of high quality, available. And I think in such a platform, of course, it is needed that the hospital and the patient ultimately gets full control on what's being done with the data, full transparency on what's being done with the data. I think that's key. And next to that, I believe that this platform should focus even more on compliancy than on quality, because I think the word trust is next to quality, the word that's been mentioned the most here. And so a compliancy platform, which is making sure that all guidelines and all critical legal aspects are being respected when the data is made accessible to third parties, is for me the first step to validate the platform. And it's not only the hospitals that want this, but I know that the industry is also very compliancy driven. And they want to pay for it. They want to pay for a platform, making sure that the data they get access to is, in fact, cleared for access. They are allowed to do it. And so that's how I would start the ball rolling. And perhaps then, okay, case by case. And their use cases are out there. And when I started Cascador Health, I was overwhelmed by the number of use cases from the industry that were waiting for data. So there's no shortage there. So money will come from industry to start those use cases. And like that, we can fund the compliancy platforms. And I think those use cases will fund the hospitals, and they can start investing in tools for improving data quality. So that's the pragmatic way how I would start.
I'd just like to confirm from the hospital point of view, we cannot do it ourselves. We need, and I will use the word, a trusted third party that is the go-between in whatever direction with industry or with government or even the patient and so on. We need that because you can't expect that the hospital is doing all that type of thing. So that's perfectly complementary, but it must be a trusted third party accepted by the community that you work in that way.
Alexandre?
Okay, I'm going to start from another point. I feel that the right word is who invests.
Say again.
Who invests, not who pays. And because I believe that in health we are investing. I give you a small example. The example of my diseases, multiple sclerosis. It was discovered by Mr. Charcot 140 years ago. Until now, we don't know what starts the disease. We are at the same point as Mr. Charcot 140 years ago. Thus, our organization, our patient organizations, our network of patient organizations that is coordinated by the Multiple Sclerosis International Federation, started 40 years ago some initiatives in order to aggregate and create registries of data of the patients. The oldest we have is the French, I think, and then the Danish. And they started collecting data 40 years ago. And now we have 22 worldwide registers that agree 5 years ago to federate their data in a way that everybody could access the bulk of the data. Why? Because we realized that, in fact, we are almost a rare disease. So there was not enough cases in each country to create the amount of data required for big data analysis. So we started 4 years ago an alliance. Is called MS Data Alliance, that aggregates almost all the MS societies in every country around the world. And we are developing this federated database of aggregate information. And one of the key discussions was exactly the quality of data, because the data come from different initiatives, come with different formats. And we established that the goal of this MS Data Alliance would be to create a minimal data set that would be coherent and would provide enough data to research and to advocacy, because we needed the evidence to advocate for better treatments and better health. And that is our example, but it's not the only one. I know that in other diseases, there are also, the patients also invest their time, their money in order to develop this area. So I would say that that's an investment and should be a common investment. All the actors should invest. And I think the patients are ready to invest their share. Is not only money, it's also time, and for sure we will try to give our best to invest in this goal, in this objective. And I think if everybody can agree that it should be a common investment, of course, with the biggest players investing the most. But I think it must be a shared effort among all the stakeholders.
Thank you. Paolo?
So I think this is a relatively complex question, and the answer is different from the different use case. Meaning, connecting to what our colleague Alexandre mentioned, so we don't have to invest a lot of money just because we want all the data, but we need to be very pragmatic and very focused on which kind of data we want. That is point one, and that is going to probably diminish the amount of funds that we need. Secondly, we need to look at what actually we want to get out from this data, to try to find a level of acceptability, so defining quality level, and therefore, and again, this can also improve the way in which we spend funds, money. What we need to invest is standardization, is to make sure that various data sets that we want to integrate together, we want to look at the same time, are in a common format that can be used jointly and seamless without losing time. In various processes, especially with data that is collected for primary use, there are already a lot of data quality check, data quality process, data quality control that may be improved, making it faster, automated. I think the challenge probably is in the secondary use of data, where the data needed to be fit for purpose for a different use for which they were collected at the beginning. And that is where there is a need for potential training around for who is going to use this information, and possibly a lot of engagement between the different group of people. For example, EHDEN Odyssey, Darwin now, is a group of stakeholders trying to get the best out of this information in order to improve public health. And all this joining, all these stakeholders is important.
Nigel?
Thank you. I mean, these are all fantastic points that I'm following, and I have empathy with all the comments you've made. I'm a recipient of Belgian healthcare, and it's fabulous, by the way, absolutely fabulous. Formerly from the UK and the NHS, and I won't discuss that. But sadly, one of the things I understand, I hope I got the details right, within the Belgian healthcare system before the pandemic even, is that, for instance, when new drugs enter the market, what industry often does, companies, is it needs to capture data, of course, what's happening in the real world for all sorts of reasons, efficacy, safety, and so on. And actually, what was a nice move, I think, in Belgium was that to create a system where there was a common registry or database set up, and then as companies joined that market, if you like, with the new therapy, they contributed to that data collection, rather than each company create or support an existing registry or create a new registry, a new data capture. Again, putting more and more pressure on healthcare systems to double, triple entry data and so forth. And it makes a lot of sense. So we can be very innovative with what we do already, I think, to improve the system. Secondly, I think I would definitely agree, I hope it won't get struck by lightning, but representing the industry and life sciences, we already are, but we definitely should continue to contribute in terms of resources and in kind, and also financially as well, to data quality. It's in our interest, so why wouldn't we? There is an important stakeholder, and I always sound like a stuck record here, but it's a common theme, and it's the same on this panel. We don't have any real representatives of large-scale EHR or data capture vendors. And I hope I'm not being unfair, but a lot of what we talk about in terms of data quality is really sticking plasters on top of root problems in terms of the original data capture. And we all know a lot of the reasons why there are problems. But one of the fundamental things is we definitely need to have not just fit for purpose data and so on. How do you get that? Well, you have fit for purpose data capture systems that allow healthcare workers to get on with the stuff they really need to do, ensure that we survive and live and are cared for, but have ease of use of ensuring that the systems meet their needs in terms of clinical care and decision making, and then capture the data appropriately for secondary use. We're not there yet. Many of these systems are not fit for purpose, and we definitely need to ensure that we have representatives from that community here. And two things. One is discuss how they will invest in improving quality of their systems, which intrinsically would hopefully improve quality of the data. But secondly, that we have enhancement improvements and more power around procurement systems, inclusive for hospitals, I would say, and other providers, to ensure they do get the kind of capture systems they need, and we all want to benefit from in terms of secondary use of that data. So I think that's a critical omission also in terms of the investment that needs to come from that part of the healthcare industry. This is going to be a long and iterative process. We would want governments to pay. We know where we are economically, internationally. It's a very challenging time again. So I think currently I definitely agree with a number of the comments. I think in particular, I think from relation to that we have to work with the use cases we have, the data that we do have, and work from there. And then things that are financial aspects, whether it's investment which results in an ability to invest, then if you're sharing data or allowing interaction with your data collaboration, let's call it more that than data sharing through things like federated systems and so forth, whether that's a cost recovery approach or indeed there's a revenue generation which is then fed back into the system. There's various models that we can look at. And also many of our therapeutic interventions, advanced therapies and so forth, biologics, high cost, variable volume, and often the cost of that is now becoming increasingly amortized over a period of time. And so we need to look at these as very longer term investments, not just i.e. this year or next year, and I need the data to provide an answer to the question I need for the regulator or the HTA agency. We actually need to invest in this long term in terms of a long journey of capturing data for various different industry and other developments.
Thank you. So we covered midway now, and so my second question is to ask you for sort of examples how this investment that is obviously coming from different stakeholders can really bring return of investment to stakeholders. And having said that, I also would like you to ask you to, if you can distinguish the ROI to the party who directly funds data quality from the stakeholders who gain an indirect ROI. And since my expertise area is pharmaceutical industries, I can just give you an example. And Nigel has already touched upon it. Data quality is the lifeblood for pharmaceutical industry when we are doing our clinical trials, and we are soaring of double entry and so on and so forth. So the pharmaceutical industry and life science industry will definitely be a benefactor of data quality in an indirect way. And I think, Nigel, you already alluded to that. That is important. So with that, question number 3, examples how ROI can be seen. So I start with you, Pascal.
Thank you. Just a short comment on the very positive words of Nigel about the Belgian health system. We don't trust each other, and the big advantage of that, because Belgium is just a big city, is that there was an investment in platforms to share data. That means each Belgian person, wherever he or she is going to, what kind of health institution, he or she is giving informed consent. The other side can look at the history of the data. It's for this moment static. It's not online and active, but okay, it's there. And we underestimate that, how strong that is in that system. So thanks for that, because
I do want to add, though, Pascal, there was no financial prior agreement between you and I for my comments.
No conflict. No. For me, from hospital perspective, the return on investment is a value again, because it's quality over cost, and quality is experience of the patient outcome over the total cost along the trajectory. So experience is prems data, outcome is data, and the total cost of ownership is data. So investing there, you make a nominator and denominator better. So you add immediately to value. So it's easy. Easy from hospital perspective. You have to do it.
Right, Philip?
As an entrepreneur, I need to believe in the law of the market dynamics. And I do believe that the dynamics go way beyond just financial compensation. If I was speaking to hospitals about sharing their data, I was happy to see, but also surprised to see that just getting money in return for their data was not always the primary objective of those hospitals. So, as Pascal rightly said, the incentives for hospitals are very often about improving the outcomes for the patients and becoming more effective and efficient as a hospital. So, as a third party, you should find ways to help hospitals in doing so. And for me, it's about creating insights and peer-to-peer benchmarking tools, allowing hospitals and doctors to see how they can improve their activities. So that's the first ROI I think we need to try to create. The second thing is that what I've seen in the field, that hospitals are actually quite competitive. They want to outperform other hospitals in one way or another. And I think we have to try to tap into this dynamics in the market by, in some ways, offering those hospitals that are willing to go more quickly in this field to give them first user rights in some way. Of course, from an ethical point of view, it's a delicate element. I know that. But in certain situations, it's in the benefit for society as well to have some early adopters and to encourage those hospitals that have invested more in data and are more advanced to give them access to first use of specific medical technologies. And then the third element is innovation. I think hospitals are willing to innovate, and if in return of data, they can be part of research, that's also a quite important incentive. So next to money, I think there's a whole different playground of returns for hospitals to be created, and the industry should act up to that.
So I just want to say, for the remaining questions, I urge you to be brief, because I really would like you to also answering the fourth question and then the closing remark, right? So, Alexandre?
Okay, for the patients, return on investment is linked with dailies and qualities. It's linked directly to the well-being of the person. From the perspective of the AMS Data Alliance, DA, we have also something that we want to get from the data. We want to get knowledge. We want to understand better what is going on in our disease, in our what would be the expectations that we can see or foresee for the future. And we want the ultimate goal. We want to discover the cure. So I think investment in data quality is an investment that pays.
Thank you. Paolo?
So from a regulatory point of view, the main return of investment will be being able to, how can I say, to rely, to be able to be sure of the result of the analysis that we're doing using some data, and therefore being able to rely on the scientific assessment that we do. And therefore on the regulatory decision that are taken. This is the key. In addition to that, improving data quality can also foster and speed up the time to market for medicines, because maybe some process maybe don't need to be repeated or don't need to be cross-checked, can be automated. And also, ultimately, if the patient and healthcare professional are aware that we perform analysis on the basis of data for which we know the data quality level, we know that are reliable source information, and the processes as well that we use, because it's not only data quality, but it's also quality on the process that are used. Their trust on the system, on the regulatory system, will be increased.
Thank you. Nigel?
Unusually for me, but based on your request, I'll try to keep it brief. So I'll simply say, I think we had a good example. My colleagues, Peter Reinbeck this morning, and also Maxime Monet, also presented two aspects related to overall and also to around data quality in EHDEN. And European Health Data and Evidence Network, I think, is a very good example. Is 30 million euro budget over 66 months. We're now in our fifth year. 15 of that from the pharmaceutical industry, from 13 FBO partners, 13 pharmaceutical companies, life science companies, 30 and half the other 15 from the taxpayer, actually from European Union, to pay for public partners, I might add, not for the industry. And we're already generating evidence, as Peter presented. You know, that was actually impacting on Paolo, on European Medicines Agency's decisions around vaccines, for instance, for COVID-19 and so forth. And we've seen ourselves and other sister projects within IMI, within the Innovative Medicines Institute, starting to impact on things like clinical guideline evaluation, which is really critically important in terms of the audit loop and ensuring that we're actually getting the real outcomes for individuals and patients that we need. And there is an inherent, very significant aspect of data quality requirement within what we're doing in EHDEN. And then very quickly, lastly, we polled about 60 of our data partners earlier on, to your points, Philippe, about the drivers. And money was there, but it wasn't at the top, because we provide funding for their mapping to the common data model. It was things like wanting to better utilize their own data for research, business analytics, audit, whatever, to collaborate with others, other data partners and third parties, inclusive of industry, and therefore also to have greater exposure of their data. And there was a recognition that each of these data partners' data was important, but was even more important when it was starting to be included in a much larger federated data set, if you like, as well. And so I absolutely agree with your comments. And I think we can back that up actually with some evidence as well, that there are multiple drivers here that are all positive about really improvement and ensuring optimal outcomes comparatively, as you pointed out, across the healthcare industry and healthcare systems. And it's in the interest, again, of industry to make sure that we can evaluate that, because it has a big impact on how products are used. Are they optimally used, and what are the outcomes in the real world, of course, versus what we see in clinical trials, which is a highly artificial environment, of course.
Thank you. I will take my last question, because this is leading to the fantastic prospect of what we can do collaboratively. Pre-competitive collaboration is what's coming up to my mind. So what kind of actions, collaborations will be needed to achieve this? And reverse order, and please be terse. Nigel.
Hopefully I've already answered that question with examples like EHDEN. We need quick projects quickly. We need projects like EHDEN. It's only one of many other programs and projects. Okay, so we need to realize that. But it's probably one of the largest in Europe now, creating this network and so forth. And we need to see more of those worldwide as well. They don't fix all the problems, but they act as a great catalyst. And also one of the other things is there are many of my colleagues here from small to medium-sized enterprises. And as you heard earlier today, we've trained and certified for free 64 SMEs in 22 countries in a consistent, reproducible, rigorous methodology to incorporate also quality of mapping source data to the common data model. And this is a unique resource. These small to medium-sized enterprises, these small tech firms, are now already working with their own customer base to do the same, working across borders internationally, and also contributing to the more global Odyssey, the Odyssey community. So there's a kind of a halo effect. So we need to get very good at partnership. You mentioned skills earlier, I think, and we need to ensure that we've got a very good skill base in terms of partnership for people who are doing some great work, but we need to ensure that it's propagated.
Thank you. Paolo?
The first action, I think, is going to be to try to standardize also what we mean with quality, data quality, how we can utilize the same processes. And this is one thing that we are trying to do at the European level in the regulatory network, because as came up already a couple of times during these 2 days, we are trying to publish a framework, a EU framework for data quality. And the collaboration that we would like really to have is with all the stakeholders to get their input, to get their expertise, to partner with any person that is involved in data quality to get good idea in order to improve that. For example, now the first version of the document is just terminologies, just to make sure that concepts are the same. But the next step will be really to look deeper and deeper in the use cases. The first one will be real world evidence, real world data.
Thank you.
And everyone's got until 5 o'clock this afternoon to respond to the public consultation. I think it finishes today, right?
It finishes today, but if you send some comment in a couple of days later, it's not going to be a big deal.
You all heard it here.
Yeah. So for the remaining 3, Alexandre and the others, please be terse, because I really would like to wrap up and also ask the audience one thing.
Okay, I will be brief. I think cooperation and competition are the key words for this joint effort. And I think I want to give you the openness of the patient associations to be involved. I think in your countries you will find your patient associations, and for sure they will be very much interested in participate. In Portugal, we managed to federate 70 associations, patient associations, and we made a proposal for the government about our digital data health environment, and we are discussing with them. They are listening to us. So I think it's important, especially because patient associations, as you know, we are an important and a very vocal stakeholder.
Thank you.
So please use us.
Philip?
I'll try to be very concise, very easy. the last 2 days, we all were informed on existing regulations, on the guidelines, on standards. We know what the framework is. Now, each and every stakeholder present here should define what is my interest in the ecosystem and what are my objectives. And that doesn't take too much time. Most of them of you know. And then you have to start cooking. It's easy as that. It's just, I think the framework is ready. It's just about implementing it and following your own interests and objectives in the ecosystem.
Thank you.
In the real world, there are 3 things to be successful. That's governance, that's infrastructure and excellent people. Governance, the vision of the hospital leaders and the healthcare leaders, and facilitating trusted third parties to go in between all the stakeholders and go for accreditation, infrastructure, hardware, software. And of course, excellent people. You have to train and educate not only the patient, but also healthcare collaborators in this domain.
Thank you. When I've been listening to you, and also sort of spurred me when I heard you, Philip. Some of the things that I see: priority of use cases, industry governance, collaboration, pre-competitive collaboration, fragmentation, federated, and so on and so forth, and collaboration. For those who have seen a great movie, which is called Beautiful Mind, which is about the Nobel laureate in economics, John Nash. He wrote a masterpiece in 1964, which rendered him the Nobel Prize. And you know what it's titled? Governing Dynamics. It's a simple thing. Best outcome come within the group when everyone in the group is doing what is best for themselves and the group at the same time. So it seems to me we need to drive for Nash equilibrium in every cases. And collaboration seems to be an important role to play. So I would like to thank you very much, and also to the auditorium, hand over the questions that I was given from Dipak. So are we ready for a Porto Declaration of Health Data Quality? Are we?
Yeah.
Are we? Good.
Very convincing.
I think that it would be, you know, I think it's very important to achieve Nash equilibrium, and Dipak, you have heard me ramble about that so many times. But I think hearing the panel saying the same thing and the need for that collaboration. So I would like hand over to you, Dipak, for the last closing statement.
Well, it's very kind of you, Matt, to allow me that opportunity. I know everybody's keen to eat, so I'll keep it fairly brief. I think I would like to highlight just a few messages that I felt came up consistently through the panelists' interactions. I think the first one that echoes also something that was in the calls to action I presented previously is that taking forward an ambition for better data quality is not something that healthcare does in a silo or research does in a silo. I really felt that the stakeholders need to come together, crossing that boundary, because they all need better data, learning health systems and research, public health, policy making, patient empowerment. And we won't achieve that if we have silo efforts and silo investments and even a silo ambition for what data quality means. And I felt that came over very clearly from the lovely multi-stakeholder panel. The other thing that I didn't expect, but really came up quite a bit, was the fact that sorting out an appropriate way to enable data sharing at scale, including how to address appropriately the balance between data protection and enabling large-scale learning. So the GDPR issue, if you like, intersects with the data quality agenda, that actually getting high quality data means you need enough data from enough patients with enough consistency within the data. And that means the data quality issues and the data protection issues are intertwined. And if we're going to think about a declaration, we've got to have both messages in there. And the other thing I think that came over really strongly is the prioritization of patients in this ecosystem. They have historically not been our priority stakeholder. I do feel the momentum is changing rapidly, but I really felt in this panel discussion, the need for us to engage patients in understanding about data, being willing for their data to be used, but also for they themselves to be data users, not just data providers, came across in some of the messages I heard. ROI, very, very difficult, thorny issue, but I felt there were some very positive hints about how we might start to build up the evidence and justify those investments that are needed, both the direct and the indirect beneficiaries working together. I won't say any more. I felt that was a really powerful panel, Mats, and thank you for moderating it so well on my behalf.
So I would like to all of you thank the panel and also for a great conference. So thank you.
Excellent. Yeah.